Welcome to today's Q2 Safe Everyday event. We've got 3 speakers for you today. We've got Tina Bogle, our Chief Pharmacist, doing a talk on her role and medicine optimisation. We've got Diane Bayliss from MedPro International, which is our the insurer for HSC, doing a talk on good medical records. And then we've got a talk by our own clinical audit team to celebrate Clinical Audit Awareness Week. So I'll pass you on to Tina for the first talk, and thank you. Just click that one.
I'm going to sit down because that's not very. I'll have a little rest. Not that I've been doing anything. So, oh, excellent. Oh, so let me go. So try. Okay, so hi everyone. So I'm Tina. I'm going to be talking about the importance of MedsOp and just a bit of information about my role as the Chief Pharmacist within Guernsey and the Bailiwick, because I found that people aren't really aware of what it involves. So intro, this is what I'm going to talk about. I'll give a little brief overview about me in case you don't know. So I've been in Guernsey for about just over 2 years now, and I'm from Birmingham. So I've worked as the Deputy Chief Pharmacist at Birmingham Women's and Children's Hospital before I came here, and people would ask, oh, why did you move over? So the main reason was just I wanted a bit of work-life balance and to be closer to the sea. And then I saw this job had come up and I thought, oh gosh, let's give it a go. And so here I am, trying it out, and I'm really enjoying it actually. So this is what I'm going to be talking about: MedsOp, the challenges, overview about my role, pressures, what's needed, what does good look like, and the future. If you want to ask any questions for those of you here, just ask while I'm talking. I don't mind being interrupted, but otherwise you can ask at the end if there's anything. So medicines optimisation. So this is a key term in the world of pharmacy. So medicines optimisation's a cornerstone of modern healthcare, and it's basically about getting the best possible outcomes for the patients. It's not just about prescribing the right drug, it's about a patient-centred approach, and that's really important, I think, ensuring that the safe, effective and efficient use of medicines to improve outcomes for individual and as the population as a whole. I think that's really important to us here in the Bailiwick, because we can actually change population health and prescribing and outcomes for patients in a really great way if we did everything properly and how we should. So in terms of medicines, they're used in nearly all clinical pathways, and the spend on medicines consumes one of the largest shares of the budget in HSC. So after staff, it's the second biggest spend, and we haven't really optimised it, I don't think, coming into my role from an NHS organisation, looking at how we look at the budget. So there's loads of things that we can do much better, and I think that's really important that people understand that medicines is a massive spend, but we can optimise that. So what have I written here? Effective cross-organisational medicines optimisation. So this is my key bit, and we need to look at it strategically and collaborate across the healthcare piece, not just within HSC, but primary secondary care. That is kind of where I see my role, and that's where the role of the Chief Pharmacist should be functioning, which I'll go on to. So these are the key principles, no worries, of medicines optimisation. So we need to maximise benefits while minimising patient harm. So that is the key takeaway. So it splits into these 4 underpinning principles that I'll just talk about. And that's the primary one is the patient's experience. And sometimes we forget, I think, especially from a pharmacist's point of view, we're just looking at the drugs. We need to make sure we think about the patient. And that really involves shared decision making and having a conversation, and making sure that patients are fully informed about their choices, which I don't think that we're doing particularly well as a pharmacy team at the moment. So we're good at making sure that the medicines are clinically appropriate. So when the pharmacist comes on the ward, they'll check, yes, that's great for the patient, but you know, making sure that the patient gets that medication at the right time, and that it's based on evidence. So we're using the right up-to-date guidance that's available out there. Making medicines safe as possible. So we know we're great at doing the incidence reports here, but what are we looking at? How can we prevent medication errors and adverse drug reactions? That's a key cornerstone of MedsOp. and also improving medicine's efficiency. So that's kind of getting the best value for money and reducing waste. And we don't really do that much, I think, looking at waste and how we can save things. I think where we are with Meds Up at the moment is just the basics, looking at clinical appropriateness. But I want to let people know that there's lots more that we can be doing and that we should be doing. And it really matters because actually up to 50% of medicines are not taken as prescribed. And as I said, it's a huge part of our drugs budget. And as we know, we haven't got unlimited budget, but the budget we have got is appropriate, and we can use that a little bit more effectively, I think, if we looked at it in a holistic way, and also making sure that we're looking at it in a multidisciplinary approach. I don't feel that currently pharmacy are integrated well enough within all teams, and that's something that I really need to push and enhance to enable us to kind of carry these key principles of Meds Up. So, as I said, why we're not integrated really, I don't believe, as how pharmacy should be. So these are I've kind of put a slide together about current pharmacy service challenges. Some of you might not be aware of the challenges. So this is kind of a summary. So these are what I think. The main issue, no medicines optimisation strategy. There's lots of areas, they've got their big strategies, big pieces of work saying, this is what we're going to be doing. That's not available for pharmacy, and it has never been, which is surprising for me, coming in as a chief pharmacist. There's no direction. People aren't aware of what good looks like. So that's something that we really need. How the pharmacy is structured is very different here within Guernsey. So the hospital pharmacy service, I don't believe we offer adequate support to the rest of the hospital. So we don't do discharge prescriptions. So majority of our prescriptions are all dispensed in community pharmacy. So this is not great for patients. So obviously for me it was a shock. Imagine leaving the hospital and you've got to take your prescription to the community pharmacy. It's a Friday, it's a Saturday. Mm-hmm. We shouldn't be doing that really. We need to look at why. And that's something that's always been like that, but that doesn't mean that it's right. And so it is a discharge-led nurse service with no pharmacy really support at discharge. Maybe that's kind of why it is that. And our ward support is very small compared to normal kind of hospital environments. So that's kind of what we need to look at, how we integrate within the ward, how we get our staff doing what they should be doing, the right place, the right time. And a lot of it as well is due to the digital infrastructure. So we are very behind with the UK in terms of digital infrastructure. We don't have a dispensing robot. We don't have a tracking service. We don't we use our tools that we have appropriately. And as you know, we don't have EPMA. So EPMA is electronic medicines prescribing and administration way of kind of utilising things that hopefully we should have. Some of the other issues that we do have is that our community pharmacies don't have any formal contracts or frameworks. So one of the issues for them is they get lots of funding doing all our prescriptions. So for me, if I move that into the hospital, what would that look like for them? And for me, I have to be really considerate of that. And then, the GPs have contracts with HSE, the community pharmacists don't. So they kind of get money on whatever they dispense. And currently as well, all our high-cost drugs are dispensed in community pharmacies. This is not the usual way of doing things within the NHS pathways. It's what we've done here, but that's kind of a big issue for us at the moment. We are getting a lot of pressure from external drug companies because they're not used to selling their drugs to community pharmacies. They usually get them from the hospital or home care companies. And we don't have any home care provision on Ireland. So when I say home care provision, I mean that if a patient's on long-term medicines, they have to go to the community pharmacy or come to the hospital to get it. We don't have any deliveries or any support services that we can commission out to any contractors. And that's something that I think will make a massive difference to patients if they were able to access their medications from their own homes. So these are the kind of issues that I think we need to really look at as a pharmacy service. This is just a little background of a typical service, like I mentioned. So some of you might not have ever worked in the UK, and I have obviously spouted on about how it is in the UK. You're like, well, that's not relevant to us. And I think over the 2 years, I've actually some things aren't relevant here. That we can't change everything, but there are certain things that we can look at that we can change to make it easier for us and our patients out there. So typically, this is what happens in the NHS: dispensary services, pharmacy services, and we do all of that here. The other things that we are looking at within the hospital that is not very typical is the low volumes of outpatients as well. So a lot of our outpatient prescriptions aren't done within the hospital. We don't have an outpatient pharmacy like you see at other hospitals. The poor patients have to take their prescriptions again to a community pharmacy. These community pharmacies have long wait times. They often don't have the appropriate drugs, and it's not a great patient experience. Within the hospital, we look at regulation, licensing. Everything is done essentially from a hospital point of view, but I'll kind of go into that in a bit more detail. And most of this sits with me. So the difference here, so I'm the chief pharmacist of the whole of the bailiwick. My remit is this, and it's a really huge remit. You wouldn't get that within the NHS. You would get that within a regional chief pharmacist, where I think people haven't really understood the concept of what my role is. So this is just a little summary, just so you're aware of what I have to do and deal with. So government island-wide, so the chief pharmacist is the head of profession for all of the pharmacies. So basically the pharmacist technicians, anybody that's employed by a pharmacy, I am kind of the regulator for all pharmacy practice. My position should be advising ministers, looking at strategy, looking at policy, looking at legislation, making sure that we're compliant with the most up-to-date legislation, and supporting the whole of the bailiwick to do that. Regulation, I am the regulator for pharmacy, so all pharmacists and technicians have to be registered with our GPHC, so that's the General Pharmaceutical Council, but they don't have any official standing over here in terms of the standards of community pharmacists. So I have to go in and do the inspections. If there's any wholesalers on island, it will be the licence has to be issued from me. All the controlled drugs and medicinal cannabis sits under the chief pharmacist roles and responsibility, and that's island-wide, including Alderney as well. My corporate responsibility, so within HSC, meds optimisation, patient safety, governance, EPMA and digital systems when we get them, and linking in with the UK bodies, so such as the medicines regulatory, so the MHRA. I have meetings with them, with the GPHC, with the Home Office. Kind of, I'm the equivalent person here for all of those bodies in the UK. Operational, so professional leadership and oversight, that's kind of what I said before. Education, looking at how we support pharmacist and technician career progression, and that's the same with primary care. All pharmacy related services within primary care sit under the regulation of me, and I support third party providers such as the police, Orchard Centre, prisons and care homes. Any medicines related activities, once again, it's me who has to deal with that, and all community PGDs and all hospital PGDs have to be signed off by the chief pharmacist. So as you can see, just a small remit there for me, with my massive team of not that many people. So what's needed? So I think I've come into this role thinking, you know, there's so much we can do. We can make it. There's so much we can do to make it really good. But what does that look like, and how can I do that as one person? How do I sell that? How do I make people really, think, yeah, we can do this? So one of the things that I do want to look at. So I did this a while ago and I thought about a strategy, but I think now I'm looking at a smaller document, which is going to be a framework. Just so sometimes strategies are a bit boring. Nobody wants to read them. They're reams and reams, and it doesn't get anywhere. You just invest a lot of your time, and without many positive outcomes. So I'm looking at a framework that people can really get involved in. I really want MedsOp to be valued and recognised politically and strategically, and that's where I need to really be voicing my opinion and making sure that I'm heard in the right meetings, the right things, and people understand what that is. Primary care is critical to the change in medicines optimisation. I really need to integrate community pharmacies as part of the primary care groups. It's all kind of GP led. GPs are a business here. Community pharmacies are too, but they're not utilised enough. We just wasted a resource from what I can see. My role to be recognised as a regulator and a strategic implementer rather than an operational role. I'm not here to be operational. I've done that before. I didn't come here to kind of do operational work, and that's kind of where I've been for the past 12 months. I am getting a new associate director for pharmacy, and that will come and do the operational side of it, so will support me to be able to lead strategically and do kind of what I think I'm good at, which is helpful. But I can't do that on my own, so it has to be a collaborative approach, a systems-wide view on Medicines Up. It's not just HSC, it's all areas of the bailiwick, so I have to make sure that I'm speaking to the right people, and a lot of those people are external to HSC. And make sure we have appropriate staffing levels. We know we've got an issue with recruitment and retention, but pharmacy staffing levels have been the same for the past 20 years, and that's just not good enough to provide the service that we should be doing to the wards and in community. So what would a good pharmacy service look like? This is what I think. Digitally enabled, we all know our infrastructure is not great here, but generally in pharmacy we are really far behind. We don't have access to the spine, the NHS spine. We don't have electronic prescribing. Even in community, we can't send our prescriptions over to, the GPs, and the pharmacies don't talk to each other. We need to really look at what that looks like. I know now we are looking at that in primary care, but I need to be in those conversations. It has to be the right people. And that's kind of joined up working to make sure that people understand, actually, I need to have pharmacy in this conversation. I need to speak to the right person to make sure that we are doing what we can. Safe staffing levels across all pharmacy areas. So as I said, my role spans across, so it's not just a hospital. I need to make sure community pharmacy is also well looked after. To me, this is like a basic. Patients counselled and receiving medicines before they leave the hospital. This is such a simple thing that we need to get right. That will really, I feel, transform patients, how they feel about the hospital and the pharmacy in general. Safe transition of patients across care settings. I don't believe that we do a good job in that. Hopefully EPR and EPMA will help, but we just need to make sure that we are making sure that there's a safe transition of those patients and their medicines are getting updated. We get so many issues with the GPs not updating patients' medical records. As we know in community, it's one of our biggest issues. States-wide information on med safety and effectiveness. I really want to, my role in the next 12 months will be pushing that out there across the whole of the states, not just within HSC. Sustainability, we always complain we haven't got enough money, but actually our pot for drugs is reasonable. We just need to utilise it effectively and make sure that we're spending money appropriately, and other areas. So now we've, with the help of finance, I've kind of consolidated the budget within pharmacy, so it all sits under me. So now we know what we're spending, where I think previously we didn't have that really good oversight. So we're hoping now we can start looking at making things more cost effective and using what we've got effectively, rather than complaining we haven't got enough money, because we know it's not a magic pot of money. And quality driven, quality is so important. Looking at data, we've previously been really data poor within pharmacy. I have got now a data analyst, which is really amazing. So let's track what we're spending, look at what we're doing, and make effective decisions using data, not just because I think as the chief pharmacist this is what we should be doing. And when I make decisions, it has to be data driven and not just personal. And I think that's a culture shift really within the states of Guernsey from what I can fathom within my role. And that's kind of how I work. It's not about me, it's about the system and how it should be better. So that's what I see a good pharmacy service look like. So this is just a summary. I know I could speak for ages about my transformation plan. It's just something that I put together, under the headings waiting without harm, with patients, work, life and waste. These are the things that within my framework I'm going to be looking at. What can we do to make it better? But as I said, I do need the strategic support to be able to do that. Within pharmacy, the resource isn't great, and I have been lucky enough to be provided with a couple of roles, but as you know, it's hard to recruit into them. But this is what I want the journey to kind of look at and go through, have governance frameworks, when we have that strategy in place, make sure we're doing things right and effectively and manage our medicines appropriately, look at quality improvement, how can we do discharge right, what does that mean, have the pharmacists and technicians integrated in the right places, and having the right conversations. Currently it's difficult because a lot of things come through me and people don't know what they should be doing, who they should be going to. So I'm hoping over the next 6 to 12 months it will become clearer and people will be able to link in with the right people. That's kind of my plan. Focused areas, as you all know, as I said, we need to make sure we're doing the best with the resources that we've got. So the main things in terms of focused areas for medicines optimisation is polypharmacy and de-prescribing. So polypharmacies, we have so many patients on so many medicines, they're not reviewed. We need to look at that. We're doing loads of great work with Falls, trying to get, and I was asked, can we have pharmacy support? And I'm like, you can, but I don't have anyone to give. So that's kind of our issue at the moment. There's such great work going on within HSE, but sometimes there's not enough resource from pharmacy to support that work stream, and that's what I kind of really want, to be in a position that I can provide that and support everybody. Antimicrobial stewardship, actually we're doing really well with that. We don't have an antimicrobial pharmacist. We have got the funding for one, but it's really difficult to recruit to, but we do support on that. Our biggest area really is going to be high cost drugs and value-based prescribing. It's a massive area. The UK are really hot on it, so I've been given the funding for a high cost drugs pharmacist, and I'm trying to recruit to that will really look at the appropriate, so that is all the nice TA drugs things, so we don't have the same access as the UK do to medicines, and I really want to make that possible, but we need to look at what we're prescribing and how much we're spending. So that for me is an important process for the next 12 months to make sure that we can have that. We deserve that as an island and a population, but we need to make sure that we are utilising our budget appropriately, and that's kind of the key areas that we're going to be looking at in terms of MedSop. But to make that happen, I hate these flies. We need that collaborative and multidisciplinary approach, and that's the reason I'm doing these talks, is to engage key stakeholders, to let people know what it means, what I'm trying to do, involve the right people, make sure they involve us at the right time. Pharmacy always get left to the end and then for some reason expect us to do what you're asking, but I don't work like that. You need to include me from the start or you're not going to get everything that is, I'm going on the wrong way. I'm happy. Wrong way. I'm doing it. I figured it out. Look, that's because I was being mean and saying that I'm not going to help. But I think it's right to include the right people at the right time. Otherwise, then people are spending a lot of time looking at projects and doing things. But you need to remember, the team's really small within pharmacy. I'm trying to grow it and get better, but we need to be involved in the right conversations. And that's dealing with cross-sector integration, making sure that primary care and secondary care speak to each other. My role is that enabler, and I need primary care to realise that in terms of across the care settings, and then develop the communication channels to make sure people have access to the right people. That if you need to speak to me, I'm available, or if you need a member of the pharmacy team, they are there at the right place at the right time. So kind of that's the collaborative approach that I want to see going forward. Integrating pharmacy and the team. So yeah, that's me. Medicines Op is essential for delivering high quality care. We need to maximise the drugs that we're using, look at what we're using appropriately. So a call to action. The chief pharmacist role is critical. So my role is looking at the overall strategy, the whole system approach. It's not just the hospital, it's everything. And next steps, we want to have a look at further collaboration between pharmacy leadership, strategic operational teams, drive innovation and effectiveness in medicines. And I think over the last 6 months, because I did this initially in January, I feel I am progressing, but it is slow, but it's positive, and that's all I can ask for really. So yeah, thank you, that's me. Any questions? And I keep doing it, going on to your wonderful slides. I'm so eager. So anybody got any questions or anything they wanted to ask me? Oh, God, please do.
You spoke about high cost
Yes.
medication. So I work in outpatients where we do the infliximab.
Yes,
and
yes. All the MABs,
yes,
all the biologics.
mAbs, all the
Yeah.
mAbs. And there's talk about other ones coming on board
Yeah.
for certain programs like migraines and things like
Yeah.
that. And just interesting hearing. Does anyone ever look at what good are we doing?
Yes.
Was this better than the old way, or is there something else?
So
And I
we
guess
have.
that could come with the audit side of it as
Yeah,
well.
we do have a prescribing unit, so that comprises of Mark and Geraldine, and they're really good at looking at what we're spending and what we're doing. So we do look at that, but the issue, I think, is that lots of these are getting dispensed in community, and then they don't have access to the same prices that we do in the hospital, and we don't have any home care companies to support us with delivery. So we are looking at it, but that's kind of one of the reasons that I asked for the high cost drugs pharmacist, because we're using all branded medicines. We haven't switched over to a lot of the generic medicines, which have the same effect, you know, the same clinical effectiveness, but a much cheaper price. So that's what I think, if we had the resource, which we have been given, I just need to find the right person to be able to lead on that work stream, then we've got the money to utilise effectively. Does that make sense?
Yes,
we are,
it's a bit
so we are
complicated
yeah.
too. Like when you're doing an outpatient, you have to do it for private prescription
Yeah.
and on the drug card. And
It's very complicated.
doesn't make
So it doesn't.
intuitive
It's not. So
sense.
lots of our work streams
It's not
aren't.
intuitive.
Yeah, they're not. If I'm perfectly honest. So there's loads of streamline like we could do, but I just haven't got the resource to do that. I can't do that. I shouldn't be doing that. And we just do. So once we get the high cost drugs pharmacist in, that will be their like baby, and they'll be hopefully doing that, looking at the process of, you know, prescribing, where they're getting it from, what we're doing, how we're doing it, what drugs we're using, because, you know, these are high cost drugs. They've got lots of monitoring, lots of, you know, side effects. We need to be able to show that we're utilising them properly and doing the right thing for the patient, because at the moment we're trying our best within the system that we've got, but it's not. Yeah.
What would be really useful is to have you know how the wards have a pharmacist come on rounds.
Yeah, it
It
would.
would be really
So-
useful.
And the wards don't
For
even
other
have enough. So we
patients.
have 4 clinical pharmacists for the whole of the hospital.
Okay.
So every ward doesn't even have their own pharmacist. There's no pharmacy technicians on the hospital. So yes, it would, but they need to give me that. So in the budget, I'll keep on asking. I'll ask again. But I did get. I was looking. So I did get. So 3 positions. So that high cost drugs pharmacist would support outpatients, and because it's part of that, that's where they're prescribed. But where I don't have a specialist pharmacist for elderly care, no pharmacist for community. So there's lots of areas. Mental health, I've got Carolyn, but she's a deputy chief op. So it's, you know, 4 clinical pharmacists for the whole of all of the patients in the hospital. It's a bit. So yeah, we're trying to get there, and we are slowly. So yeah.
Tina, you should know this and I don't. So you've got the budget for HSC. Do you have the state insurance budget as well?
So we're looking at. I don't have the insurance, so I have now the community. All. When you say that in.
So the
Yes.
community pharmacy
Yes, that sits under me.
prescription. So
Yeah.
that sits directly with you.
Yeah.
So the polypharmacy that goes on
Yeah.
in the community pharmacy.
Yeah.
How can that be tackled? You know, multiple amounts of fortified drinks,
Yeah.
laxatives, PRN meds that you might just need for if you go on holiday.
Yeah.
All that sort of stuff costs a
Masses.
huge amount.
Yeah.
Can that be rationalised?
Yes, absolutely. So I'll keep harping on about the UK. So in the UK, the GPs have their pharmacists that they employ. And one of my biggest issues is they're all private businesses here. So when I start my strategic work, I'll need to get primary care to fund at least 1 post, so that pharmacists can sit in their clinics and go through and rationalise the prescribing. My biggest issues at the moment is a patient gets discharged from the hospital. There's no electronic discharge. It goes to the GP. That takes how long does it take? A month?
Sometimes weeks.
Yeah, weeks, a month. Who's
Months.
update in the UK? There's a pharmacist that gets that. They update the system. The patient's record gets updated, and then the next time they have a prescription, they get their updated medicines. How our system works, the patient has about 6 prescriptions already in the community pharmacy waiting because they issue multiples. They come in for, an admission, their meds change, the GP doesn't know for a month or two, they go back to the pharmacy hasn't got any electronic record, so it's just a waste. So what I'd love,
might be using different pharmacies.
yeah, because we don't have
and a couple of scripts with a different pharmacy.
direct discharge or direct, patient can't choose where it goes to. So basically my plan is to get them to fund, but the problem is the budget doesn't sit with them, so they can keep prescribing.
Exactly.
And it doesn't affect them. But then that's why we need to look at it as a systems approach. It should be affecting them. So how do I that's my challenge. I haven't figured it quite out yet, how I get them to understand that we need to change. So one of the roles that we've been approved is an interface pharmacist. So they will look at deprescribing when the patient's an inpatient, but how that translates into primary care, I don't know yet. But if I can show that it works here, I do need that. It's a spend to save, but they need to spend the money, and I need to work my magic to get them to do it. So yeah, wish me luck.
Will that system link with, because I know I've seen a few incidents where obviously somebody's been in the UK for an outpatient appointment or it's an inpatient, and then obviously we're not getting their prescriptions coming back here, and then the doctor doesn't want to write it up because it's just written on a piece of paper that they've come back with, and it again creates.
Yeah, so that's the whole work stream that I need to look. That will be part of my remit, but I just don't have capacity. But we need to. But we're not. And it's a massive piece of work to get access to the NHS spine. That will need digital transformation, not just me, and it's not really on the government work plan, I don't think, to have that. But I think Jersey are looking at it, so I'm going to link in with them, and then just they're very kind to me, so they help me out. So we'll see. But yeah, that's a bigger strategic piece of work. But that's kind of where I see my role in making sure that they're aware that we need to have these pieces of work on the government work plan. So yeah, that's where I envision myself.
Any other questions for Tina? Well, thanks very much, Tina. Thank you. Just if anyone wants to make themselves a cuppa, we'll just have a 2-minute break and then we'll start with Diane's talk. Thank you. Thanks, Tina. Welcome back. And for those that are watching online, welcome back. I hope you're still with us. We've got Diane Bayliss from MedPro International, who will introduce herself doing a talk on documentation. Thanks.
Okay, thank you. Hello everybody. My name is Diane, and I'm going to be spending the best part of the next hour talking to you about the importance of good documentation. As Tammy said, I work for an organisation called MedPro, and MedPro is the company that provides this healthcare system with medical malpractice insurance. A little bit about me: I'm a registered nurse by background. I worked in hospitals for many, many years, but for the past 14, nearly 15 years, I've been working in this patient safety, risk management, education role. And so I'm really, really pleased to be asked to come and talk to you about this really important subject, because good documentation is integral to patient safety, and it's also really important from a medical legal aspect as well. And I think if we think about it, I'm sure many of us will agree that our documentation is not always as good as it can be. And this is a point that's brought sharply into focus when we're asked to explain maybe the management and care of a patient that's quite some time ago. And that's the challenge, isn't it? Because on one hand, we are aware, we know that it's good practice that we must keep good documentation, but then on the other hand, it's often like a balancing act, isn't it? We've got all these other things, constraints, and namely time. So these are some of the things that I'm going to look at over the next hour. As with any good educational event, I have some objectives. So we're just going to reinforce what the function is of and benefits of good medical records, highlight some of your professional responsibilities, and then share some practical tips. So I would hope that you would pick up maybe 1 or 2 hints or tips at the end of this session that you could put into use. Okay? So these are the things that we're going to look at. But to start with, I'm going to ask you a question. Who thinks they've got a good memory? Oh, Claire puts a hand up straight away. Okay.
Not
Anybody? No. We might think we've got a good memory. So I want to ask you 3 questions. Don't ask me just yet. 3 really easy questions. What were you doing this time last week? Last Monday? What were you doing this time last month? The 2nd of May. I'll make it easier. It was a Friday. And thirdly, can anybody remember what they were doing the 2nd of June 2024? So, can anybody answer any of those questions? A week ago, that was easy. Well, we had a bank holiday in the UK. Did you
Yeah,
have
we did.
bank holiday?
Yeah.
So you all had the day off?
Yeah.
That's easy. Oh no. Okay, what are you doing? So you could probably remember a week ago. That's really easy, is it? What about a month ago?
It's easy for me
Friday
to
the
go on
2nd
holiday.
of May. You were going on holiday,
I was
Jenny?
on holiday, so I do remember.
Ah, you
quite
remember
right.
it. Where were you on holiday?
In Portugal?
In Portugal. Okay, so Jenny could remember it because she was on holiday. Anybody else remember it? It's only a month ago. Oh, Leslie there.
Because I was on holiday as well.
You were on
I
holiday.
was doing it with a friend, so I know what I was doing.
So you can remember it because you were on holiday. Anybody else on holiday? No? What about a year ago?
Oh.
2nd of June 2024. Anybody remember? It's only a year ago.
I was, and the other reason I can remember this is because I was in my last couple of weeks of my contract in the Falklands, so it was something a bit different.
So it was
again.
something a bit different. Okay, so there's a bit of
I
theme
didn't
there,
remember.
isn't there?
Yeah.
So we remember things that are significant. Holidays, we remember holidays, and you were in the Falklands, so it was significant to you, so it was different. And we just tend to remember things that are significant, don't we? Because our brains do this great thing, it tags memories. And the 2 of the things that tags memories are around emotion and significance. So very often we'll remember something different, a wedding, a holiday, a birthday, or some kind of event. But if it's just every day, we won't remember it. The chances are we won't remember it. So if you think about a patient maybe coming into hospital here, they may have a better recollection of an event, what information they were given, what examination, the care they received, because it's more significant to them, okay, and probably more emotional, yeah? So we remember things, but the chances are, if it's just another day at work for us, we won't remember it, hence why we should try and remember things, yeah? So that's one thing to remember to begin with. We don't have good memories, yeah? Even though if we think that we do. Claire said she put her hand up, said she had good memories, but she couldn't remember what she was doing a month ago. So, you know, so that's the first thing to take away for you. So if we think about what is the medical record, and this is just one definition that's saying that it's a medical record on paper or electronic format, provides a written account of the patient's medical history containing information about diagnosis, treatment, chronological process, and just discharge recommendations. So that's just a generalised thing. But if you think about, so what's included in the medical record? Anybody? What's included in it?
Demographics.
Demographics, diagnosis, treatment plan,
Allergy status.
allergies, lots of things, yeah? Theatre notes, handover sheets, basically everything that's to do with the patient's journey in the hospital or wherever they're being cared for, isn't it? You know, and I think some things that often get forgotten about, so for example, emails, conversations with a colleague, does that get documented? It all forms part of the patient journey, so it all should be in there. And good records can demonstrate a lot of things, can't they? We use good records to provide high standards of care. So I'm sure you're very proud of where you work and you hope that you provide a really high standard of care. So that should be reflected in the record, shouldn't it? Records I think this is an important one, continuity of care, provides continuity of care. So somebody else can pick up the care of that patient and have a look at the records and know exactly what's happening and what needs to be done with this patient, okay? So if you think about continuity of care, that's really, really, usually, if you can pick it up, if Claire handed over a patient to me and I could just look at the records and know exactly what was going on, those documentation was probably is good enough for most purposes, yeah? But we use the records for lots of things. Audit, our clinical audit ladies over there, you know, and also from my company, it's about using them from a legal point of view as well. So records are important to many, many different areas. But I sort of said at the beginning, we know that we should be making good documentation, but we don't always do that. Why? What are the barriers?
Human factors.
Human factors. What do you mean by that, Jenny?
Starting with what you have already mentioned, the so-alleged lack of time.
Lack of time.
Yeah.
Yeah. Anybody else?
Staff shortage, which also leads to
Staff
that.
shortages.
Maybe people who don't have very great English language skills.
Yes. So communication. They don't have English as their first language, perhaps.
Distractions.
Distracted. You're in the middle of doing something, and somebody says, "Oh, Dawn, can you just come and do this, please?" And then your train of thought's gone. Anything else? I've got a few
It's like
here.
lack of collective working.
Yeah, lots of things. It's time consuming. I know my patients, this is the doctors, there's no doctors here today, but, you know, I know my patients, I'll remember. But we know that they won't. What about, I'll put can't type. That's another challenge when you go onto electronic records. I've always done it this way, I've never been sued. Why do I have to start thinking about that now, okay? You know, you probably in Guernsey you don't have that kind of litigious society that we do in the rest of the UK.
Everything apart from healthcare.
Yeah,
Actually.
yeah.
So it's very litigious.
But it's coming.
already.
It's
very
coming.
bad.
It's coming down the line. Yeah. So if you kind of get all the good practice in line now, so when it does increase, because it will increase, that's just the way it is. Too busy. No formal training. I did this training to a group of 25 consultants in a hospital in Ireland, and I said, who's ever had any training on how you keep records? Not one of them.
Gosh, that's true.
Okay? They do it now in med school, in the training, but the old school, you just pick it up as you go along, yeah? And sometimes you just pick up the bad habits as well, okay? So what are the consequences? So does it really matter? What's going to go wrong? Okay? So it could, the patient could have something go wrong with their care, okay? Significant event, something going wrong with the patient's care because of the records. And I could give you lots of examples of this. Something not documented, patient not given a diagnosis, test results not conveyed because it's not been documented in the records. Many things like that can go wrong. And it causes a lot of stress and frustration to colleagues. Maybe you're looking after that patient and you pick up the records and you think, I haven't got a clue what's going on with this patient, so you have to go through everything right from the start, okay? So it's time consuming. It could result in a complaint to your professional body, so the doctors, if it's GMC, nurses for the Nursing Midwifery Council or whatever is your regulatory body. And at the end of the line, it could end up in a court of law, okay? So I'm hoping, I'm trying to persuade you now so far why we should keep good records. And for those of you who like data, here's some data. So MedPro does a lot of business in the US, and we've got a huge number of data, and I'm sure you all know in the US they like suing doctors and hospitals, okay? And nurses as well get sued a lot now there. And so this is some data from our MedPro database, and it's from 19,000 cases over a 10-year period, and they looked at factors that contributed to something that had gone wrong in that patient's care or contributed to that patient deciding to sue. And as you can see here, 17% of those cases included documentation. This one is from some data from a company called CRICO, and CRICO are the Harvard Risk Management Foundation, and this is a huge amount of data. So this is 37,000 claims from the US, and looking at all those claims, they found that if there's absent or insufficient documentation, the case has 76% more chance that they're going to have to pay out on it. Okay, and they also found that if there was an issue with the documentation, the price that they pay is a lot higher as well. Okay, so we know that there's a direct link to patient safety and to things that are going wrong in care, and the amount that the insurance company have to pay out when the documentation is poor. So professional responsibilities, any doctors, they have the general medical practice, General Medical Council's good medical practice, and it gives them strict directions about what they should do with regards to documentation. Okay, it tells them what they should include when they're documenting, and this is in their good medical practice. For nurses, we have the NMC's the code, again, which gives you direction that you should complete all records at the time or as soon as possible afterwards, complete accurately without falsification, and they should be attributed to and make it clearly written, date and time, etc. Okay, so they're very, very specific guidance on what you should do. Now we know that patients have got a right to see their records. So back in the day when I started out nursing, if anybody is as old as me, the patients didn't see the records, okay? But now we know that patients have got the right under the Data Protection Act. So don't write anything that you don't want the patient to be able to read. And that's really, really important. So they can request to have a look at their records. Yeah. So if we think about everything that we've got to document, it's quite challenging, isn't it? And so we've got to look after the patient as well. We're understaffed, all those different things. So I'm just going to go through some what, when, and where, and what to be wary of when you're documenting, just to try and give you some hints or tips. Okay, so who documents in the medical record? Okay, so the person who has delivered the care should ideally be documenting in the record as soon as possible afterwards. Yeah, nobody's disputing that. We're all in agreement with that, aren't we? Okay. However, there are occasions when you might be asked to document on somebody else's behalf. Again, that should clearly state that you were documenting it on request by such a person. Yeah. And strictly speaking, they should really check that what you've written is correct as well. What needs to be documented? Okay, so assessments, any interventions, patient response to the interventions, acknowledgement of test results, referrals, patient notification, follow-up, any significant developments or changes in their condition, interactions with the patient, including patient teaching. You know, if you've spent a bit of time trying to educate the patient, it's really good to document that in there as well. Significant conversations, and also unexpected events or incidents. But also it's important that you should know what your organisation's policy is with regards to documentation as well. Now, I know here you've still got a bit of a hybrid. Majority is still on paper, some things in electronic, and there are plans afoot to go electronic. Is it later this year or next year? Who knows? Yeah.
I think
Who knows?
Great question.
A great question.
it's going to be in phases, but I think starting from next year, I think.
So I mean, there will be challenges, but one of the best things with electronic medical records, it does all this for you. Okay, it's all done. You know, it has a standardised structure, and it's in it reflects the continuum of the patient of care. Whereas at the moment you have to write in everything, you know, the date and time, etc. So that's one of the good things with the electronic records is that it does do all that for you. Yeah. But also I will say, you know, I mentioned before that try and document as soon as possible afterwards, after you've delivered the care, because the longer the gap, there could be some scrutiny as to, well, why was that there is a delay there. Some people might be familiar with SOAP. Has anybody come across this before as a bit of a structure on how to document things in the records? And SOAP is something I know lots of doctors and lots of nurses use it as well. And it just gives you structure, so you just make sure that you're just being objective and that you're including everything. So it's S stands for subjective, so what a patient tells you, what's their problem, history, medications, allergies, etc. Objective, so what do you see, what have you measured, what observations, you know, if you check the blood pressure, pulse, etc. Your assessment, what has been concluded or what's the differential diagnosis, and then what is the plan. And again, that's just one way of having a structured approach of documenting in the records. Any questions so far? No. Okay. Okay. So when we go to documenting unexpected events, because things do go wrong with patient care, doesn't it? Statistically, something about 10% of people who go into hospital, this is an international figure, about 10% have some kind of adverse event. My husband was in hospital last month, and I went to visit him one day, and he said to me, "Oh, the doctor just came and apologised to me." And I said, "Oh, why?" And he said, "Oh, you know the jabs they've been giving me twice a day, just blood thinner." I said, "Yes." He said, "Apparently I should only been having them once a day." And they prescribed them twice a day. So the doctor came and apologised. And I was like, okay, there you go. One of the 10%. You know, didn't do any harm. But things do happen. So if something does out of the ordinary, an unexpected event, it should be documented. But again, it's really important to be factual. Absolutely factual about what happened, the patient's reaction, who was contacted, or any follow-up treatment. I did think about when my husband told me this, I'm thinking, I wonder if they documented it or if they filled in an incident form, but we'll see. Please don't try and document any speculation or reference to any legal stuff in the patient records, okay? If you do fill in an incident form, that should be separate.
I was going to say, I think it's routinely expected that if our staff, particularly those on electronic record keeping, I'm thinking of where you work, if you do an incident report, it's expected that it's in the notes, isn't it? The incident report number so-and-so completed. So I'm just wondering why, what's the particular reason? Because we're the opposite, it's not just maybe included, actually we're directed to include it in the patient record.
Oh really?
Yeah,
the whole report?
No,
oh, right, yeah. But the actual report, it should be separate from the patient records.
It should be, although frequently it is copied and pasted, to be honest.
Right.
But
It shouldn't be in there.
at the very least, it would say rather like instant report completed number etc.
Right.
But that would make sense to actually document that you have incident reported, whatever happened with the patient, but not necessarily details.
Yeah, but you don't keep the actual report in patient records.
Often it's the organisation.
Often it is. Okay.
Is that your advice to not do that then? We
Yeah.
just have the incident report number in?
Yeah, we would advise you not to have the incident report in there. Okay. So this is just an example of documenting on how not to do it and how ideally we would prefer you to be doing it. You know, like I said, it's about being factual and objective. You know, so this is a patient who was, it says, accidentally gave 75 for pain. Okay, if you were absolutely objective about it, you would put 50 milligrams was prescribed, but 75 was given. Okay, try not to put in words like accidentally or in error and things like that. So if you just look at the difference, this is just totally factual.
Yeah.
Okay. It's about just being factual, because that's actually what happened.
Yeah. Okay.
ideal. Okay. Again, so with regards to documenting communications, again, these are things that often get missed, is communications. You've had a conversation with somebody regarding the patient, and that sometimes doesn't get put in the records. Again, things like that should be documented, always including dates and times and the details. Any questions there?
I do have one. I do
Yeah.
understand from an insurance perspective why the accidentally shouldn't be there, but the way, the example you have given, doesn't it give a bit of subjectivity? So wouldn't that allow room for people to speculate? Why is it prescribed as such and has been given as Z? Because it's not written in there.
I would say it's quite objective, because that's what actually happened. That was prescribed, but 75.
But I, from an audit perspective, I would ask, why was it given differently from what was prescribed?
Right.
Because it's not written in there. From my
Yeah.
point of view, it's not well documented. It's
I
saying
think
what
one
was
of
given,
the,
but not why.
from a legal perspective, one of the reasons why we would prefer that you didn't put in things like accidentally, error, and etc.
Yeah.
So because from our experience in the States, where everybody uses electronic records, so what the plaintiff's lawyers are doing, they will get a copy of the records and they will just do a search on a word like accidentally,
Yeah, of course.
and then they'll find
Yeah, that's what I was
something
saying, yeah, that I
to sue
understand
about.
that.
Would it work? Would the workaround be that if those types of things are put in the incident report, because that's where we probably would want that content.
Yeah, you'd
of how it
absolutely. Your incident report would go into greater
Yeah,
detail.
Yeah. And then it's just the patient notes part,
Yeah.
which is the.
Absolutely.
When you speak about electronic records as well, so when you have a conversation with someone and we document it in our nurse's notes, I've also learned now how to add it onto our electronic system, so we are double
Okay.
documenting.
Right.
But I suppose eventually it will get better.
I guess it's just that
We
change.
do double document at the minute, don't we?
Yeah.
Everyone says, well, you must document, no, it's fine. But now I've been told, oh, you
We
must
do it
also
on the
document
system.
on track on the acute nurse's record.
Right. And I guess that's just that changeover period, isn't it? Eventually you will just be all completely electronic. And I think the challenge is that changeover period, isn't it, when we've got a bit of both really. Yeah.
Or could you document it on track and just put a thing like sort of conversation held documented on track?
Yeah, but you are documenting the story both.
But then so then you wouldn't have to handwrite the whole thing. You could document the whole thing on track and then just put a note in the handwritten notes, see track.
I also like to have it in the
Yeah.
yeah.
And that's, I think it's
just the lay of the land.
Yeah.
Can
Yeah.
I just ask, how long have you been doing this?
Just maybe the past 2 months, month.
And who,
People said there's an
directed
acute
you to
toggle.
do it?
Sorry?
Who directed you to do that?
To write on the acute.
In the chat notes?
No, in the nurse, in my narrative of looking after the patient if something happens,
Yeah.
and conversations with doctors and drugs and things.
Yeah,
But
so,
they were
so
also
the reason why I'm
documented
asking them, the medical records manager, is just that when we do subject access requests, we're only copying the paper record nursing notes because we don't expect the acute nursing notes to be on track in the noting section. We only expect community notes to be in there. So if that's what you're doing, we need to
acute nurses, it does.
We need to know that we're actually-
nurses.
But it's not on
acute.
policy as well.
copying them. Yeah.
So it needs to be, we need to be aligned and we need to follow policy. So the care records policy does not allow you to do that specifically.
Okay, well,
So-
let's pick that up after.
Yeah.
Yes.
After.
So
yeah.
yeah. Something in acute is saying to do this now.
That sounds like a good point for a discussion. Yeah.
I'm making note of that and we'll pick it up.
Okay.
Yeah.
So what I was just talking about being objective when you're documenting rather than being subjective, you know. So don't speculate. It's about absolutely just being factual. Right. Okay. What do you think of this?
Oh, our daily life.
fairly standard.
Yeah.
documenting.
What do you think? Do you think is this good? Is this good? Is it messy?
What's your impression?
For what we isn't it? It's a mess.
Okay, it's a bit messy, isn't it? And it's not an old one, too old. That was from 2021. It's not from here, by the way. It's one from the UK. Okay, so I don't know if you can see. Could anybody figure out what's going on with this patient?
She's been counselled for a total abdominal hysterectomy and bilateral tamping ovarectomy, I'm guessing.
Right, yeah. So it's a gynecologist doing a hysterectomy on this patient, okay? She's now suing him. Things didn't go as well as she planned, and when patients decide to sue, I suspect the lawyers encourage them to, they make a few different allegations, okay? It's not just one thing, okay? It's usually a few different allegations. And very often consent comes into it. The patient will often say, well, if the doctor had told me that if he did X operation, there's a possibility that this would happen, I wouldn't have had the operation. And I say to the doctor, oh, the patient says that they didn't tell them. And he said, of course I told them. I always tell them. It's a known risk of this kind of surgery. Okay, where did you write it down? Okay. So with this one, he's written counselled about TAH, total abdominal hysterectomy. One of the allegations that this patient is making against him is that she would have preferred not to have had surgery. She would prefer to have had, a non-surgical treatment of her problem with her fibroids, and he didn't give her an option. Okay? So the problem the lawyers have is he's just written counselled about it. Okay, he's not written down, and it wasn't in the consent form as well. That he's discussed it with her, the alternatives. Okay, because you all looked at that and went, oh gosh. Okay, because quality reflects professionalism. Okay, and we make inferences by looking at the records. Okay, and sometimes poor records may suggest poor care. Now, we know that's not always the case, yeah? But if you're showing it to a lawyer, okay, they can infer that it's not been great care because the records are messy and haphazard, and so perhaps the doctor had that kind of an approach to care. And also, there has been some research that has backed up that. The BMJ Quality and Safety had an article a few years ago, and they concluded that the quality of recorded information in the patient records seems to be a predictor of the quality of care. Okay, so again, bearing that in mind. So here's the challenge, isn't it? Yeah? How much do I write? I said it's that balancing act. So if we think about it as a scale, so with this side of the scale is somebody who writes reams and reams and reams and reams and reams. Sometimes that's almost as confusing if they've got time to do all that. And then at the other end of the scale, there's somebody just writes very, very little. Okay? But realistically, the majority of us would be in the middle most of the time, wouldn't they? Okay? I've had conversations with doctors at either end of those scales. That I had a conversation with a really lovely GP who said, I've been a doctor for 40 years and this year I was reported to the GMC by a patient who accused me of all kinds. He said, but on that occasion, he said, I wrote the best records of my life about this patient because I just thought there was something off, okay? So he was able to provide the evidence to refute all these bad claims. To the other end of the scale of, it was another GP who we settled a claim on her behalf, and she said, because the first thing you do after you had a solicitor's letter is you go and look in the records because you think, I can't remember this patient. And she said, I was shocked how poor my records were. They were awful. And she said, I was embarrassed about how bad they were. Okay, so most of the time we're in the middle, aren't we? And I think from a nursing perspective and from all the other perspectives, we're probably the same. But there will be some occasions when we need to write a bit more. When would that be?
When there's been an adverse event.
Yeah, an adverse event, absolutely. You'd write a bit more. Anybody else?
Admission point, discharge point.
Yeah.
An emergency.
Emergency.
I think that in that situation that you were just talking about, where the GP said, "I got a feeling," I think
Yeah.
sometimes you just get this innate sense of this consultation
Absolutely.
hasn't gone how I thought
Absolutely.
it was going to go.
So, patients who are not happy? Do you get patients who aren't happy here? Yeah? Okay. Maybe you think, oh, I'll just write a little bit more. She wasn't very happy about what our plan was. Or if they don't agree with the management plan. Or if the patient's seriously unwell. Okay, you're going to write a bit more. Young children, babies, maybe a little bit more. Or if a patient lacks capacity, for whatever reason. And what if they have unrealistic expectations? Now, everywhere I go, people say to me, oh, patients have higher expectations these days. Because we know everybody goes on Dr. Google. I need to have this test and this MRI and all these things, yes. And so you have all these high expectations of fancy treatments that they can get in the US. Well, I don't see why I can't have that. So, you know, because patients have a lot more access to information these days. So there's lots of things, but Claire's absolutely right. Sometimes it's just that little sixth sense, so you just think, I'm not quite sure, I'm not really happy here. I'm just going to write a little bit more. Yeah. So thinking about when you should write more. And also a few other things, if there's diagnostic uncertainty, complex, if there's unexpected progress, safeguarding, okay? Safeguarding vulnerable adult or a child, or if, you know, maybe the doctors need to make an important decision if it's high risk. So these are the kind of at times when you maybe write some more notes. Okay, so as I said before, document as soon as possible, hopefully before you go off shift. Okay, record the date and time, make sure it's attributed, and try not to predate entries, and try and keep late entries to a minimum. What about the occasions? Sometimes you write it in the wrong records. Okay? If it's in the wrong records, and forgive me if I'm incorrect about what your policy be, would you just put one line through it, written in error, date and sign? Is that right? Yeah. Okay, so you're not obscuring the original text. Yeah, so that's quite straightforward, isn't it? So how about, Dawn, you're a nurse? What? Nurse associate, right. So Dawn's just had a really, really busy shift, and she's gone home. She comes back in the next morning and she thought, oh gosh, I forgot to write some information last night on my shift about Mrs. Smith. Should she go and write it now?
Yes.
Yes.
Absolutely. Yeah, because it's better that it's there, isn't it? It's better that it's there. So what should she do?
Date and time, the time she wrote it.
Okay.
So
Writing
our-
it today's.
So our electronic system, it captures both. So it captures the time. It asks you when was the activity. So if
Okay.
it was a conversation from yesterday that she was documented, you would put yesterday's date for the date of activity, and the time and date of note, six separate.
So that's
electronically
absolutely
that
clear.
works.
And that's a great thing about electronic records, isn't it? Because you can't get away with anything. It tracks everything. That's how Harold Shipman got caught, wasn't it? Yeah. But with the paper records, and it's absolutely it's relevant to the patient's care. So it's absolutely right that it should be in there. But again, you just have to be totally overt about it. Written, inputted on such a date with regards to such a date. And write the information down.
That's quite relevant for the, as you very well highlighted as well, for the continuity of care.
Absolutely.
Because otherwise it will kind of
there's a
confuse
missing
it.
chunk.
Yeah.
If you just think it's the patient's story, isn't it? Then there's a bit of the journey that's missing, or a bit of the jigsaw. So to have that in there is really important. Okay. So please don't ever just try and alter records, because again that just looks suspicious. And if you're not sure about what to do, go and speak to somebody in senior or this lovely lady here that's saying, okay?
There's lots, I used to do a lot of training on documentation. There was lots of NMC hearings where people had, for the actual error they'd made, it wasn't like that big a deal, but for if they'd covered it up, changed the records, whatever, they were really
it's a privacy issue, isn't it? Yeah. And the same with doctors. Again, I know a case of a GP who he used to do a clinic with his practice nurse, and they take lumps and bumps off, and he would do the procedure and he'd leave her to do the documentation. It was about 12 months or even more than 12 months later, there was a claim from one of the patients, and he went into the records. That's the first thing you always do. Can't remember this patient, have a look in the records. And he realised that what the practice nurse had been documenting just was not good enough. So he inputted what he thought should have been in there and lied about it. He got suspended for 6 months because it was a probity issue. Okay, so that's really, really important. So again, try and avoid using these kind of descriptive words that I just mentioned before. Let's go to the next one. Now, we like using acronyms and abbreviations, don't we? Yeah? Here's just some... Can you tell me what these are? What's that one? Okay.
General Post Office?
Can you read that? These are from back in the day that we used to see in records. Now everybody knows this one. Yeah. Anybody ever work in A&E? Apparently that's a well-known one. Oh yeah, we all know that one. Yeah. Okay. So these are a bit funny, and fortunately nowadays, because we know the patients can have a look at records, we don't see these, but a few years ago we did. But actually, some more serious abbreviations could be misunderstood. So I say it's always better to write what you mean rather than using abbreviations, unless there's a policy of abbreviations that you're allowed to use. Is there? There's not an actual policy, okay? Just try not to use them, because again, they could be taken into a different department. Again, another story from a GP, he said to me, I had a communication from my local hospital A&E department that one of my patients had been seen in the A&E the previous evening with an STI, which he took to be a sexually transmitted infection. But he was quite concerned because this was a 13-year-old girl. So he thought, this is a safeguarding problem. So escalated it, reported it, okay, only to be really embarrassed when he found out what an STI was. Soft tissue injury. Okay? So, you know. So taken out of context can be misunderstood. So it's always better to don't use abbreviations if you can.
I've seen that IUD one happen a few years ago.
Really?
Yeah. Taken out of context, yeah. And
Yeah.
it was very upsetting for the patient.
Yeah. Yeah. I'll tell you something funny. My husband's been in hospital recently on the cardiology ward. And I went in one day and he said, oh, well, my PR's okay today. And I said, oh, what? And he said, my pulse rate. And I said, Mark, you don't abbreviate pulse rate as a PR. To a nurse, that means something totally different. You know? But he thought he was being clever, okay? So please try not to use abbreviations or those. And again, some prescribing abbreviations can cause real problems. Yeah. Yeah. Okay. So where are we at now? Handover. How am I doing time? Okay, I've got 10 minutes. I just want to quickly talk about handover. Okay, handover, we know that handover is a real error-prone patient safety area, yeah? And it was back in 2007, way back then, that the World Health Organization said that organizations should have a structured approach to handover. So, that's my question. Do you use ISBAR at all, or have a structured approach?
ISBAR. Sometimes SBAR.
Well, this is like it's SBAR, but we've put an eye on it. Okay, there's variations on this. Okay, few people nodding, you're familiar with SBAR or ISBAR. Okay, it's a structured handover tool, making sure that you're communicating that information to another party, whether it's handing over a patient from one department to another, or just handing over your shifts. And it's just really, really good to have this in the sense that we put an eye on it, on SBAR. So introduction, identify yourself or the patient. S is the situation, so what's the patient's current diagnosis? Is there any alerts? What's going on? Background, so what's been happening with the patient? What's their patient's background? The assessment, so providing the details of the plan of care, and then response or any recommendations. So this is a good one to use handing over the shift to the next your colleagues. But I think this is a really important part as well, read back. Okay, so I've just told you about Mr. Smith, and then you read back to me. Okay, Mr. Smith, he's got this, he's done this, watch him overnight, Dr. So-and-so needs to know if his blood pressure drops, whatever, okay. And read back or teach back is a really, really good communication technique. And I try and get through to the doctors when I do sessions for them about doing read back or teach back, especially if you're relaying information to a patient, and we know that they don't take it all in, what they're telling them, you know, and it's, you know, so Mrs. Smith, I've just given you a lot of information there about your condition and your new medication. So just so I know that you've understood, just tell me what you understand, okay? I went with a friend of mine to for a consultation. She was just having some minor surgery. She's a teacher. She doesn't live in our medical world. She'd never been in hospital before, and so she was just going for her outpatient's appointment and asked me if I'd go with her. So I did, and the consultant was explaining the procedure and risks and benefits or whatever, and I was very good. I sat in the corner. I didn't say a thing. And he said, have you got any questions? No. I understand, sign here, whatever. And she was nodding. And we walked out and she said, I've no clue what he was talking about. Yeah? Because she was so nervous and upset about being there. And I actually thought he did quite a good job with the consent process, because I was listening. But then in hindsight, he was talking about, well, there's possibilities of DVT and things like that. You know, people that do live in our world don't understand that. Okay, so if he had said to her, right, just relay back to me what I've just told you, what you understand, he would have then understood that she hadn't taken most of it in. And very often that happens with a lot of patients, doesn't it? You know, even from the nurse's point of view, you're giving them, you know, discharge instructions, and you say, okay, yeah, fine. And they weren't listening at all because it's just too much, okay? So read back or teach back is just a really, really good thing to adapt. Okay, so handover is really, really important from a patient safety point of view, because again, we know that the communication gaps between healthcare professionals is where things can go wrong, handing over to a different department, different team of doctors or nurses, okay? And you should have systems in place to assist with good handover. So using a structured approach like SBAR, and you can go online, there's lots and lots of tools out there, but just having some kind of structured approach, and just again to help patient safety. Summary. How am I doing? Okay, I've got 4 minutes. I've caught up. Okay. So the 5 C's of good record keeping. I'd say contemporaneous, okay? Document as soon as possible afterwards. Continuity, just thinking about telling the story, okay? Making sure that somebody else can pick up where you left off. So all that information is in there. It should be correct. It should be legible. Again, once you have the electronic records, a lot of this problems go away, okay? Only use recognised or approved abbreviations. Remember, it's your professional registration. I think we need to remember that, those of us who are registered professionals as well. And again, at the end of the day, it's confidential as well, so just making sure you remember about the confidentiality of records as well. So, I'm going to ask you to think about 3 things as I'm just going to finish. So if you think about going back to your workplace, think about the continuity. Does your documentation completely tell the full story? Is it factual? Is it dated, time, and is it complete? Secondly, do you communicate information clearly through documentation so that others members of the team understand what's happening with the care of that patient? And then thirdly, do you know your organisation's policies and procedures? Okay, a few things to think about. So, that is a whistle-stop tour. I could talk all afternoon on this, but we've got 2 lovely ladies on next. So, has anybody got any questions? No, it's all clear. Yes? Yes?
It might not be the quickest one, it might be a quick question, not necessarily the quickest answer, because I do think it was kind of a hard one. But from your experience as a registered nurse and working in insurance, what trends have you identified, or why do you think that we keep finding these issues? Because I'm a registered nurse myself, working for more than 20 years, and why do we keep struggling with this? Notes not legible, not complete.
I'd be a millionaire if I could answer that. Yeah? Well, who knows? It's those barriers, isn't it? It's those challenges. We're short-staffed, haven't got enough time. I was in the middle of doing it and somebody called me away, you know, and it's, I think it's also about focus, not having a focus on how important it really is. And I think in this day and age, we need to have a focus on it, because from a medical legal point of view, if anybody's ever had a complaint about them, the first thing you would do, you go and look in the records. Because, like I said before, the chances are that you won't be able to remember what happened with that patient. Because it's not always when something goes badly wrong that they sue. Sometimes you think, why? Yeah. So I think it's also about training, and it's about focus, really, making it as a priority, and that's really, really challenging, isn't it? Yeah. Yeah. So if anybody would like to give me some feedback, if you wanted to, I'll send it to Tammy, maybe you can send it out. But my session that I've just done is CPD accredited, so just make sure you get your certificate for your revalidation. Got mine coming up soon. Okay, thank you very much. Thank you.
So next we've got just 15 minutes, Jenny and Ali from the clinical audit team. Thanks.
What the presentation that Tina and Diane so brilliantly did just now, couldn't make our presentation more meaningful. Why do we need to do clinical audit? What is clinical audit? We don't have much to add now, I think, but we'll still try our best. So we are starting the Clinical Audit Awareness Week for this year, which is from today till Friday. There are significant and different events, especially taking place with HQIP, because they are the main event providers for this. So I would advise you to go to their website and check those. We do have the Clinical Audit Heroes every single year. We haven't had the chance to have nominations for HSE staff. We are still aiming to do that, hopefully over the upcoming years, not taking too long, because we have been advertising these for quite a while. So that's one of the reasons why we wanted to bring this theme to you, just kind of a gentle reminder of the work we do, and we know you do as well, and we keep wanting to promote it and make it more visible across the organization. So what is clinical audit after all? A lot of people say it's a tick box exercise, and we do acknowledge that, but we would like for those boxes to be ticked to be improving patient care, promoting best practice, making care safer, and identifying trends and stimulating change as well. We've just heard so many issues that we find just with the pharmacy department, the challenges they are facing, and with care records as well. Can't we do all of this by putting and promoting implementing some clinical audit processes in place? I'm sure we can. And why is this so important? Florence Nightingale herself was one of the finest examples of what clinical audit is, especially during the Crimean War, where she highlighted the importance of hand hygiene through audit. That was one of the main things that we got from Florence Nightingale and inherited from her practice. So clinical audit does, or at least we hope it does, shine a light on current care. And to give a bit of more ideas on why clinical audit is so important, I'd like to share a quick video with you. Let me see if I get this right. With all those benefits, because you have seen them firsthand yourselves and you are experiencing it, and we just want to make it a reality through every single service area in HSE. That's what we are always trying to do here. And one of the biggest examples of that are the national clinical audits. Some of our HSE staff are involved in national clinical audits. And the reason for that is because they benchmark delivery across different organizations. They allow us to adopt common audit tools instead of keep reinventing the wheel. They, of course, improve care, and they also aid transparency via public reports. And that's one of the major aspects for me, because being transparent and allowing the public to understand how the organizations are performing and how are we keeping them safe, it's highly relevant. And of course, CQC seems to like them a lot, so being involved in national audits might be a good thing, and not only because it pleases CQC, but because CQC is the organization it is, so they are inspecting, checking, auditing the care being provided across the UK. We don't have them here, but we do have our own accountability and our own responsibility towards our patients, and that should be above everything else. It also highlights great care, promotes wider quality improvement, and provides a national picture so everyone can understand if we are, as an organisation, performing as other organisations in the UK might be performing, which is always a good thing. Some of the national audits we do have in HSE currently. We have the NGR, the National Joint Registry, and the National Hip Fracture Database in the orthopaedic services. We have the Cardiac Rehabilitation National Audit in the Cardiorespiratory Unit. Embrace Maternity Services, of course, it's one of the ones we have been having for longer in HSE. We also have Parkinson's, led by the amazing Debbie Rebillard. We just joined earlier this year the National Cardiac Arrest Audit, led by Judith Adams, who very adamantly and diligently have been kept a database of her own and managed to understand where she was, where HSE was, and when we could join the national audit, which we did earlier this year. And we are hopefully, fingers crossed, about to join SNAP, the Sentinel Stroke National Audit Programme, where we have Kath Dye as our stroke coordinator, who we have been supporting since 2020, we as the audit team, with keeping audit data in date, benchmarking with SNAP reports and SNAP data from the UK, and we are about to join this national program as well. We have been part of it a few years ago, and due to many different circumstances, it was a bit lost on track, but we are back on board now. So yes, some people or most people might not know, but HSE is indeed involved in a lot of national audits. And how about local clinical audit work? Where are we on that? Ali will give you a bit more detail about it. I would just like to introduce Ali and give the word to her, talking about what we as the audit team could do and do for you. We help you save lives by improving care. We allow to pinpoint key actions that need to be put in place. We also facilitate national clinical audits, as I've just mentioned. Yes, we do juggle a lot of projects, and it's not only setting up audit tools, believe me, that's just a very tiny piece of the work we do. We expect to be able to assist you and support you to become agents for positive change, because we believe we are as well agents for positive change. And we might call ourselves as data analysis ninjas, not because we do data analysis for you. Unfortunately, the audit team, it's just the two of us, so we don't have the capacity to do that across the organization. But we do know resources and tools that you can use that we might assist you with to actually do it yourselves much more easily. That's what we all are aiming for. We do also help with identifying training needs within your teams, within your service areas, and also, of course, shine the spotlight on the great care by driving quality improvement in HSE. So on that note, I'll give the word to you,
Thank you very
Ali.
much. So yeah, as Jenny said, thank you very much. I'm Ali, I'm the Clinical Audit Advisor. So I work with Jenny to support everybody across HSE with any audits. So I came from a background of working in the NHS where we were super keen on audits. What I found so far is that actually on the surface it looks as though HSE isn't so keen, but I've dug a little deeper and actually there are lots of really good audit work happening across the service. So a few local bits and pieces to mention. So midwifery and paediatric services are ongoing with documentation and drug audits. The community nurses have completed some really good skin bundle audits, including some audit reports, which is fantastic to see. ADS do lots of environmental and financial audits. Mental health services do medication audits, and acute services are just starting a falls audit as part of their falls committee rather. So local clinical audit tools. So what I've found since I joined my role in November is that there is lots of audit activity happening, but perhaps not in the format that we'd like it to be, and not in the best way for people to do these audits, or the easiest way. So this is just a little example of, ironically, what I would call the most boring audit, and the one that people probably identify as the most tick boxy. But I suppose if our Florence did it, then that's a good example, you know. So this is a hand hygiene audit. This is the tool that has been devised and is used now across HSE in most areas. And it just is an Excel spreadsheet, but has handy drop downs, identifies exactly what you're supposed to do, how many caseloads, and clearly identifies your auditable standards. This is what we're looking for when we ask for audits. The next slide shows what that data comes up as and is easily identifiable, so that when you're looking at your data, how you're improved, how you're doing across the year or years, you're able to identify it nice and easily. So as I say, lots of clinical audit activity happening. So my job at the moment is trying to get myself out there, trying to get people to engage with me and Jenny to try and improve that audit activity, and working with lots of different services to transfer audits from a Word document, which they're having to manually count and work out exactly what's going on, over to better tools so they can actually identify that data. The other thing that I'm doing is working on, and got my foghorn out and telling everybody that from 2026 we are expecting everybody to follow the actual audit policy. That involves providing our team with the clinical audit annual plan. This is so that we are aligning with the HSE's policy and we can actually see what the strategy is across HSE. The other thing that I am pushing is that all audits must be registered with our team. Again, this is not for us to say yes or no, it's for us to support you with that and identify how we can help. The other thing is our audit SharePoint site. So what I've also found is that lots of people do an audit activity but keeping it secretly away in a different compartment from us. So working hard to get everybody onto the same site so everybody will eventually have access to all the different areas. We can share that learning, share that data and hopefully improve care across HSE. We're going backwards, we don't want to do that. Centrally registered audits ensure that any insights gained across the services can be shared, allowing the organisation to consistently demonstrate its commitment to quality improvement, which is what we're all about in the quality team. And the other thing that I'm pushing towards is everybody familiarising themselves with the audit policy, which is on the audit website, along with a how-to. I think that's everything, really.
Yeah, I think so.
Yeah,
thank you, Ali. Okay. So we have been talking about, and since I joined HSE and started working within the broader quality and patient safety team, within the audit team particularly, we have been talking a lot about complying with the policy which was already in place before I joined the team and still seems to be quite hard. And there's, again, the same sort of rationale, shortage of staff, time limited and time consuming that these processes might be. But if we use them to well document our practice, we will for sure keep our patients safer, which is the main objective of it all. And of course, work alongside what Diane just highlighted, and we just talked about documentation, which is a significant, highly relevant part of our daily jobs, that we do need to audit, and we do need to make sure that they are complying with regulations and all the requirements and local policies as well. So it might be time to possibly stop talking and start doing. Because yes, Walt Disney seemed to be the author of this quote, and it might seem to be related to his fantasy world, but it is an example that we shouldn't be living in fantasy anymore regarding audit, and big dreams can come true, as Walt Disney make his truth enough. So yes, we should just aim for it and make clinical audit a reality in HSE. That's why we are here. So thank you very much. Any questions? Oh, we were that good, Ali. Well done. Thank you.
We'll go home. Thanks. Right, thanks everyone. That's the end of our sessions, and we'll see you in September for quarter 3. If you've got any projects or improvements you want to share, then just please contact me at tammy.buggays@gov.gg.
Thanks.